this lesson, we are going to be going over the different heart defects that cause an increase in pulmonary blood flow. And the information that we're going to be talking about is just going to be building on what we've already discussed in the congenital heart defects lesson. So you make sure you check that one out if you already haven't. This information is really exciting and fun for me because we get to put together kind of the patho and the anatomy. And it's just really a cool thing to be able to talk about and understand. So I hope you feel like that when you finish this lesson. All right, so the defects that cause an increased pulmonary blood flow are atrial septal defect, ventricular septal defect, atrioventricular canal defect, and patent ductus arteriosus. So we're going to talk about each of those specifically, so it's not so overwhelming. But essentially, these are all abnormal openings in the heart. And so let's just think about the anatomy of the heart for a second so we can understand exactly what's happening when we have these specific defects. So remember, the pressure on the left side of the heart is greater than the pressure on the right side of the heart. And the reason for that is because the left side of the heart is pumping against all of the pressure of the systemic vascularization, where the right side of the heart is just pumping against the much smaller pulmonary circulation. And so when you have holes in the heart, like these defects that we're talking about, the blood is actually going to naturally move from left to right. So you get what's called a left to right shunt of blood. Now, these holes, we're going to talk about where they're all located, but the majority of them are located here in the septum. And the septum is this middle part of the heart here that divides the left and the right side of the heart. So when you have this blood moving back into the right side of the heart, this blood that's already been circulated and already been oxygenated is coming back over here and mixing with this unoxygenated blood, and it's recirculating back into the pulmonary system. Now, what this does is it essentially is making that right side of the heart work so much harder. And so you can end up with having some right-sided heart failure and some right-sided hypertrophy of the heart as well. So that right side is working extra hard. Now, one thing to know about this is because the blood is mixing over here in the left side of the heart, I'm actually going to clear this drawing here because it's getting a bit mixed. But once you've got that blood mixing, there in the left and the right side, but in the left side of the heart, the blood that's leaving is actually pretty much going to be fully oxygenated. So these patients are not necessarily going to be cyanotic at first. So let's get started talking about each of these different defects and highlighting the things that are unique to each one. The atrial septal defect, or ASD, is where there's a hole between in the septum between the right and the left atrium, and you can see it there in the photo. And again, what's happening is you've got oxygenated blood shunting over to the right side and recirculating through the pulmonary system. A lot of times patients with an ASD are asymptomatic for a really long time. So you may have children who have an ASD and you don't ever know about it. But what they could have is they could have a murmur. And if they do have symptoms, it's probably going to be things like dyspnea and frequent respiratory infections. Now, when these present in adulthood, adults may complain of heart palpitations and shortness of breath as well. One thing to be familiar with is that when these patients go undiagnosed, they are at risk for having atrial dysrhythmias and developing clots, and then also they're at risk for stroke because of those clots being formed. Ventricular septal defect, or VSD, is when there are holes or a hole between the right ventricle and the left ventricle. And this photo here is actually showing you a few different types that you can have with a VSD, but all you need to know is it's a hole between the left ventricle and the right ventricle. And again, blood that's circulated or oxygenated is moving back. It's shunting from left to right, so it's being recirculated through the pulmonary system. And often how symptomatic the kid is just completely depends on how large the defect is. If the VSD is really, really small, that child may be completely asymptomatic. But larger defects are probably going to present within those first few months of life. And they usually present with sweating with feeds and feeding difficulty. So they really are struggling to have enough energy to feed. And they're also just going to be tiring easily. They've got tachypnea. And that failure to thrive, which means they're not gaining weight and growing like we would expect them to because they're not feeding well. And then they can also have a loud systolic murmur. And then over time, if it's untreated, that right side of the heart, again, because it's working so hard, is going to have hypertrophy, and then you can have signs of heart failure develop as well. Atrioventricular canal defect, it's a much larger defect than the others that we've just talked about. And it's actually an opening between all 4 chambers of the heart. So the right atrium and the right ventricle are open to the left atrium and the left ventricle. And again, same principles apply. Blood is going to shunt from left to right. And so that same blood is being recirculated through the lungs twice, increasing that pulmonary blood flow. And this is actually the most common heart defect that is seen in patients with Down syndrome. So that's really important to be aware of when we have babies who we know or think are going to be born with Down syndrome. We have to know that so we can be ready to act quickly when they're born. Now, this defect, again, the symptoms depend on how large it is, but usually it's going to present within those first few months of life. And this patient, even though we would typically think that they might not be cyanotic, because it is such a large or potentially such a large defect, these kids can actually have cyanosis. But most of the time, and you'll be seeing a pattern by now, it's going to present with respiratory distress, frequent infections, and that feeding difficulty that we mentioned. They're probably going to have a murmur as well. And then as with the last ones, if it's untreated, we're going to end up with moderate to severe heart defect as that heart's having to work so much harder to pump blood throughout the body. Patent ductus arteriosus is a little bit different than the other 3 that we've talked about because it's actually not located in the septum. The patent ductus arteriosus, or PDA, it's actually an opening between the aorta, which you can see in the photo here, between the aorta and the pulmonary artery. And so we talked about this in the first lesson that we have in the cardiac lessons, but actually the ductus arteriosus, which is what this opening is, it's totally normal in a fetus. So we expect it to be there, and it's really important for a baby to have in utero for fetal circulation. But it should close after the baby is born. And if it doesn't, it's called a patent ductus arteriosus. And so blood is still going to move from the higher pressure area, which is in the aorta, to the lower pressure area, which is in the pulmonary artery. So there's still going to be that increased pulmonary blood flow. Now, for symptoms for the PDA, probably the most classic symptom is something called a machine-like murmur. And the other symptoms, as with the other ones, they're going to be worse with larger holes. And these other symptoms here, you've probably guessed by now, they're going to be respiratory difficulties, respiratory infection, that difficulty with feeding, and then actually heart failure can occur over time, but it's actually pretty rare in kids. The therapeutic management for all of these different heart defects actually can vary quite a bit. But for a VSD and a PDA, it's actually appropriate to just have some watchful waiting. So we're going to keep an eye on those kids and monitor, but they actually can close over time. Sometimes the VSD will close within the first year, and the PDA can sometimes close within the first month or so. Cardiac catheterization can be used to treat the ASD and the VSD as well. And then usually the atrioventricular canal defect actually needs surgery because it's quite a bit larger and it has to be patched rather than just closed. Medications can also be used to close the patent ductus arteriosus. So if it doesn't close on its own while we're doing the watchful waiting, we can actually give NSAIDs to close it. So, and I'm just going to explain how this works. So prostaglandins in the body are actually what keep the PDA open. And NSAIDs inhibit prostaglandin synthesis, so it actually allows that PDA to close. And this is actually why pregnant women shouldn't take NSAIDs, because we need that ductus arteriosus to stay open, because that ductus arteriosus is so important for fetal circulation. Your priority nursing concepts for a PEDS patient that has a congenital heart defect that causes increased pulmonary blood flow are perfusion, oxygenation, and gas exchange. Okay, let's recap the key points for this lesson. So we talked through ASD, VSD, atrioventricular canal defect, and PDA, which is patent ductus arteriosus. And these are all abnormal openings in the heart. And we talked about how this causes a left to right shunt of blood, which means that oxygenated blood is being recirculated through the lungs. And this causes an increased pulmonary blood flow, which can cause pulmonary congestion and makes the right side of the heart work extra hard. And the key things to note about that are that we have pulmonary congestion, which is going to contribute to our symptoms, and then we have that increased working of the right side of the heart, which can lead to heart failure if it's untreated. So most of these symptoms that we just talked about, they actually don't cause cyanosis straight away. So a lot of times babies are asymptomatic initially, so we have a delayed presentation. But when they do start to be symptomatic, we're looking for signs of that pulmonary congestion. So we've got tachypnea, respiratory infections, feeding difficulty, and any kind of respiratory distress. Your treatment's going to vary, and it can even be watchful waiting for that PDA or a VSD. And then cardiac catheterization and surgery are also used. And remember, NSAIDs can be used to help trigger the closure of that PDA. All right, you guys, that's it for our lesson on the heart defects that cause an increase in pulmonary blood flow. Make sure you check out all the awesome resources that we have attached to this lesson. Now go out and be your very best self today, and happy nursing.